Hello, my name is Kaylee. I'm a third-year medical student currently doing clinicals in the US. So, contrary to popular belief, surgery is not the only one that does a lot of procedures. Internal medicine, especially in the ICU, is very procedure heavy. So, within one day, I was able to see a bronchoscopy, an intubation, thoracentesis, chest tube placement, and so much more. So I'm just going to show you some of the footage that I have and kind of walk you through what it's like. I was able to grab some footage that didn't have any patient identifiers in it, which is kind of hard to do, like the date of birth or name. So I'm just going to show you that today. So I wake up at 5 a.m. every day for the ICU days so that I can get there by 6 for the handoff. And so you start out pretty early with rounding. That was about 8 a.m. And even during rounding, we had our first procedure, which was intubation. So basically what happened is we saw someone didn't have very good oxygen saturations. They had just been taken off of it, actually, like a couple days prior, and we saw that they were declining, so we decided to put them back on the vent.
Can you pull out the rigid just a little bit?
You done? Are you
A little bit. There we go. Perfect. Thank you. Confirm placement, Dr. Small?
Yeah. He's
Placing the vent seemed very successful at first. They were already putting like the x-ray order to make sure that everything was in place, but then they realized that he was still not saturating well, so they had to go ahead and look all over again, see if it was the tube was in the right place, try to find out what was really wrong, and that took a little while.
Oh, before we get to that.
Well,
Wait, come back a little bit.
Where's the carina?
Yeah, I think you're in the right place.
Yeah, I look like I am. That is toenail.
There's no carina.
Come back.
I see it.
Yeah.
Yeah,
So
no.
you're in the main stem. Go back. Okay. So what you can do is wait. Keep your scope in.
Hold on.
And now we can pull this. We're at 20 cents a lip.
Okay, hang on.
Please come back 2 centimeters.
Okay.
Could be the palate.
Well, you are right on the carina.
Okay, all right. That's beautiful. Yes, Claude is absolutely right. We can come back 2 more centimeters.
Yeah, a little bit.
So after we were sure that it was in the right place and he was saturating well, like in terms of oxygen saturation, we were able to finally continue rounds, got a chest x-ray to confirm it was in the right place again, and you sometimes get a blood gas just to make sure that within the time that he wasn't oxygenating very well, was he okay. So then soon after rounds, we wanted to do a bronchoscopy to explore, because basically what happened is someone was intubated and they had something in their mouth, like some sort of cotton, and then the cotton actually became dislodged, or we just didn't know where it went basically, which the most likely explanation was it just fell out and was on the blanket or something, but we didn't see it, or no one documented like, hey, I found a gauze, because that's pretty common.
And see this hole? Just go and show them the hole, the superior segment. See this hole? That's the manhole.
That's
Turn
the
the
manhole?
scope so it looks like it's more posterior. You see how it's a manhole? You can
That's
the superior segment. That's the soup seg. The pulmonic science is called a soup seg.
The soup seg, right middle lobe, the long stem. The right middle is the long stem with 2 segments. Right lower lobe here. It should be ALP, right? ALP? Anterior, lateral, posterior. Gorgeous. No foreign body. Okay, going left main stem. Lingula. How is lingula? Beautiful lingula with a superior and inferior. Beautiful. I love this man. And then the left upper lobe. What is that? Tell me the name. Beautiful. And the anterior 2 subsections. Beautiful. And the lower lobe, you're saving the best for last.
Do you always check all these when you're doing an endoscopy?
We what?
Do you always check all of them? Even though
Usually, you're trying to look for endobronchial lesions out the right. Long left main. You have to be an assistant to what I'm doing. See what I'm doing, Andy? See what I'm doing? You don't pull the tube out. So right. So this is left lower lobe. It's a dynamic compression. So left lower lobe here. That's left six seg. You just had some dynamic compression. You notice that? Down in the lower lobe? Yeah. You come out. Let's just look at this again. Just observe it. Take time and observe. Listen, be in the moment.
is that your epidermis?
When she'll say she these accessory ducts, see those ducts? That's bronchitis. You can see the redness, that's bronchitis too. So there's not a lot of secretion, minimal secretion, if any. Scans, as they would say, and some bronchitis, accessory ducts, and no foreign bodies, Okay, so come out slowly and just let's measure from the trachea. Yeah, there's the carina. And just for an exercise, measure how far above the main carina are we.
So we went searching for this gauze in the bronchoscopy, and luckily we didn't find anything. So the assumption is she either swallowed it and pooped it out, or it was somewhere on the bed, like the most likely. But it was definitely very cool because you could see like the entire lung anatomy. And something very common that happens in the ICU is that patients require CVVHD, which is hemodialysis. So then they need a catheter that goes in their neck. And once we get that, we can plug them to the machine, and then that like filters their blood. So we did that. We put in a catheter, which is pretty similar to a central line as well. It's in the same area. And the catheter placement can be pretty mild in comparison to the other things that we do, like in comparison to the next thing that we did, which was a thoracentesis. So a thoracentesis is something that you do when there's like liquid in the pleural area, so like your lungs, and then you have the pleural area.
How you doing there, man? You okay?
Relaxing.
Getting a nice massage here from the ultrasound machine, you know?
It seems like, so this is liver, diaphragm, and then is this the most liquid, or this is all?
Hypoechoic would be the liquid, right? All that white stuff immediately would, it's gotta be tissue again.
Oh, that's all tissue?
Yeah.
And if you can't tell by now, we use a lot of imaging. Like a lot of things are guided by an ultrasound just to make sure that we have the right placement. We're not poking anything we don't want to. And once you drain the fluid, you send that off to a lab. And then actually pretty soon after that, someone came in with an empyema, and it was like his whole lung almost was just pus at that point. Because what happened was this patient basically went to Mexico, got an infection, and then had it partially treated. And if you have something partially treated, that kind of breeds all of the worst bacteria. So it got worse and worse and worse until he eventually came over here. And for empyemas, you usually have to place a chest tube. It's not just going to respond to antibiotics like a regular pneumonia. So we had to put in a chest tube, and it was immediately that this guy drained almost a liter. So like with pleural effusions, you're not going to have that much, but if you have an empyema, you are like, that's why usually you put a chest tube so that it can continuously drain, and then you have a giant thingy next to it. So yeah, it was a very like procedure heavy day. It was very medicine heavy day. So we intubated someone, we went fishing, we went fishing for the gauze in the bronchoscopy. We were in someone's thoracic cavity when we went to get the pleural effusion liquid. We put in the chest tube, we put in the catheter so that someone can get hemodialysis, and all of these are on top of just the crazy acute things that are going on that you have to treat with medication or just listening to the patient. And a lot of times they, especially in the ICU, a lot of times they're intubated. So you kind of have to listen to their, test results instead of the person. So it's very interesting. And then I tend to get home around 8, especially when it's very exciting. I stay longer than I have to because it's just so interesting and I feel like I'm absorbing so much knowledge. But yeah, it was definitely a crazy day, and I would do it again in a heartbeat, and I hope I do get to do stuff like that again all the time. I would appreciate it if you guys comment down below what specialties you're in or what you would like to do. Also, please comment down below what's like the craziest day or thing you've seen, because that would be really interesting. So yeah, thank you so much for watching. If you like fun and informative videos like this, I post every a couple times each month, and I hope to see you in the next video. Make sure to subscribe. Look at how cute my shirt is.